let's start off with past trials. In fact, let's back up a bit and talk about 2012, when the United States Preventive Services Task Force issued their edict that prostate cancer screening was no longer recommended. And I think I'm not alone in this crowd, because almost every American urologist cried foul at this. And as we predicted, in the decades since that time, we've seen a skyrocket of advanced prostate cancer cases at presentation because of the lack of screening. So that was no surprise. However, as often happens, out of something bad, good happens. And the point made by the task force was this: we were being poor stewards of our patients. We were screening men who didn't need to be screened. We were over-testing PSA. We were over-biopsying men. We were treating men with clinically insignificant cancer. So that was what came out of that task force edict. We looked in the mirror and we said, we have to do better. And we are, but we're still not there yet. So what I'm going to do is go over the global search for a better algorithm to identify these patients, a better screening matrix. Looking back, though, the task force based most of the recommendation on the PLCO trial, which I think they'll have no argument from the room saying that's pretty much junk, at least the prostate cancer portion. It showed no advantage to screening, but the data was really terrible. The European randomized study on prostate cancer did show a significant positive impact to screening, although the task force sort of ignored this. As time goes by and ERSPC continues to look at their data, it is now up to latest review, 1 life saved for every 14 men screened. So that's a pretty reasonable number. The CAP trial came out of the UK, and like so many trials out of the UK, it just didn't really amount to much. And then the Göteborg 1 trial was the best trial that we've had for screening to date. And what it showed was that there's a substantial benefit to screening. And in fact, in the latest analysis on that, 1 life saved for every 9 men screened. So that's Göteborg 1. So what's going on right now globally? The European Union has PRAISE. And if you're like me, you look at this diagram and you think, am I looking at an integrated circuit chip or something like that? It looks like when I was a kid, I used to play with these little pegboards with electronics and stuff. It's a very, very busy study. It has 6 different work groups, and they're intermeshed and intertwined to answer their questions. So to make it even easier, we can just look at the 6 work groups. I'm kidding. This is just as busy to look at. This diagram, though, points out, and it may not project too well, but really what the EU is after is making sense out of where we are. So they're taking patients and looking at different levels of PSA, below 1.5, 1.5 to 3, and then above 3. And then if those men fall into the high risk, the above 3 category, they have a matrix of a nomogram to see if they continue to be high risk. If they're not, then they go out and back into the regular screening. If the nomogram says they're high risk, then they go on to get an MRI. If the MRI doesn't show anything, they go back into the pool. If the MRI shows a lesion, then they proceed to biopsy. And they're studying in that cohort, once we get to the final end of that cohort, systematic biopsies plus targeted versus targeted alone. So when that reads out, we'll have some more information to a fairly straightforward pathway. And it's a pathway similar to what I think most of us are trying to do, albeit not in a real codified mechanism in our practices today. Transform's another UK study, and it hasn't started yet. There's 2 stages to this study. The first stage, they're comparing best practices amongst 4 groups. One uses a fast MRI. Fast MRI is something I don't think we have available in the US. It takes about 10 minutes for an MRI. It just looks at the prostate real quickly. The second group is looking at genetic testing for risk factors. The third group looks at standard PSA testing. And then the control group in the UK is just those men who ask to be screened. So after stage 1 is complete, which is somewhere around 14 or 17,000 men, they're going to analyze the 4 groups and take one of those groups and go forward with that as their next test for risk-benefit analysis. So to me, not nearly the robust nature that the EU is taking with the previous trial I mentioned. So let's go to Germany. Germany has a PROBASE trial going, another, I think, nice, simple, and designed to answer questions well trial, where you have immediate screening or people who are delayed. And that immediate means they're age 45, delayed screening means they're 50 and older. You get a baseline PSA. If it's less than 1.5, you check again in 5 years. If it's 1.5 to 2.99, you check again in 2 years. If it ever gets above 3, you proceed immediately to an MRI with a systematic and a targeted biopsy. So that's the PROBASE study, which has yet to be read out. Again, it goes through the basic questions that we're looking at, but I think it's a little simplistic. I think it's a missed opportunity to look at some of the other ancillary biomarkers that we've discussed already today. Back to Sweden, Göteborg 2 looks at 3 groups, and this is a trial that's undergoing now. And the first group is men with a PSA greater than or equal to 3 and get an MRI, and there's a targeted biopsy only. The second group is PSA 1.8 to 2.99, and looking to see if this group of patients with MRIs discovers more significant cancers without the cost of indolent cancers. And then the third arm of the study is looking at these algorithms, not just at cancer detection, but that's the long-term arm looking at mortality benefit. All right, so that's, and then there's the schematic looking at how that's going, and they've already gotten pretty far down the first 2 arms. And with positive, I might say, with some positive implications to screening, although the second arm with the expanded screening below 3 does, as expected, have perhaps an unacceptable number of indolent cancers being found. So PROSCREEN, this is in Finland, and I think this is probably the best designed study of these I'm going to talk about. So what they've done is they've taken a PSA of less than 3. If you fall less than 3, you're excluded from the trial. And they've got numbers here to represent 1,000 men going into the trial. So after a PSA, that's pared down to about 100 to go forward, and they get a 4K score. And then they estimate the 4K score eliminates about 30% of the men. And then those that have a high enough 4K go on to get an MRI, which eliminates about 50%. And those remaining go on to directed biopsies only. And then at the end, out of that 1,000 patients entering screening, they wind up with 17 with significant prostate cancer. So the reason I think this is more in the direction we need to go is because it's somehow looking at incorporating these adjuvant tests into PSA and MRI. And then this is just sort of a schematic of where they're going with this, and they've already found a good number of those cases. What the preliminary report from PROSCREEN shows is that 1 additional high-grade cancer per 196 men invited has been found so far, at the cost of 1 low-grade cancer per 909 men invited. So this is where somebody, not me, has to decide what's the acceptable number of low-grade cancers we're going to find in order to find that high-grade cancer. So obviously, with this particular algorithm, in my opinion, we're not finding too many low-grade cancers as opposed to high-grade. Impact trial, going back to the UK, this is interesting. They're segregating screening into 2 groups. Those men who have what Dr. Gamella just talked about, hereditary risk factors found on genetic screening versus men without any genetic abnormality, and then they take them through an algorithm that they currently use with normal PSA and MRI, but it's really segregated to see what kind of impact on the general population doing those genetic screenings can have up front. Interesting, but not really, in my mind, the direction we need to go for global prostate cancer screening. Back in Sweden, there's a trial called the Stockholm 3 MRI trial. And with this, so there's a test a blood test in Sweden called Stockholm 3, and it's an interesting test. It utilizes 5 proteins. It's sort of like a 4K, but I haven't committed to memory the 5 proteins, plus 100 genetic probes. So it's a big mishmash of tests that you get out of a blood sample. So what they've done is they've taken the Stockholm 3 test up against PSA to see if it's a better initial screening. In my mind, this is really where we all need to be looking, because we can slice and dice and reinvent PSA all day long, but we need to find a better entry into this whole pathway than PSA. And so far, the results from Stockholm 3 say that it may be slightly better than PSA. Now, it's not a game changer probably, but it may be slightly better than PSA. U.S. trials, there's a number of U.S. trials going on. The first one you'll see here just looks at people with English as a second language to find out how we can impact their screening models. There's looking at MRI as the initial diagnostic tool instead of PSA. There's a test looking at PET scans as the initial diagnostic tool, which I think is probably not going to work too well. The polygenic risk scores, like everybody's talked about today, looking at those up front in the initial screen, much like that English trial impact that I showed a second ago. Then there's some African-American-based trials, one that just uses a population in Cleveland, one that uses an app on the phone to help men with their screening, trying to get more people at risk into the screening population. Another PET scan trial to look at nodal metastasis to determine whether or not men should be even treated up front in the lower grades of Gleason grades. And then there's several blood tests looking at non-invasive biomarkers for screening. And these can all be located on the NCI website. So potentials, we talked earlier today about PSA density. I think that's something that a lot of people incorporate into their daily practice. It's like we said, it's free, it's easy to get, and it's meaningful. Age-specific PSAs, so whether we're looking at breaking PSAs down to 1.5 to 3 and above, or at different ages, ranges by age, I think that is something that a lot of people are doing. Again, we don't have a systematic approach nationally to this yet. MRI is a great tool, and there are a number of studies that show that a biparametric MRI, eliminating the contrast, is just as good at cancer detection as the multiparametric MRI. And what that does is it saves some cost, it saves the potential, even though it's a low potential of side effects from gadolinium, and it makes it much quicker, at less than half the time for the MRI, so you can get a lot more out of your resources, out of your MRI magnet. And then there are all the serum and urine biomarkers that people have talked about already today. I did want to throw this up because this is a misconception that MRI is an expensive tool. I pulled this off Medicare yesterday, and what you'll see, I don't know do I have a marker? No. So what you'll see here is that Medicare reimburses in an office setting about $217 for an MRI of the prostate. In a hospital setting, it's about $295, right? So yes, MRIs used to be expensive, but that's not a costly test, especially when you compare it to all these other blood and urine tests that we've been speaking about as adjuvant tests. So MRI is a cheap marker to include in this algorithm. So that completes the update. The key knowledge gaps that I think we're looking at answering: how do we inform men that shared decision-making about what we should do? What is the optimal PSA cutoff if we're sticking with PSA? What are the ages that we start our screening at? What about when screening yields different results? When a PSA says it's at risk, but the next test down the road says don't worry about it? How do we decide which test weighs more? What are the optimal intervals for screening? What do you do with men that have a negative screen? When do you go back to screen them? The intermediate test, the 4Ks, the select MDXs, all those things, how do those fit into the algorithm? And then let's not forget cost effectiveness. Like I said, MRI is a lot cheaper than some of those other tests. Maybe we just weigh more heavily on that, like the Scandinavians are doing. What about not just screening and detection, but the long-term effect on mortality? We can't forget that as we try to figure out how we screen. And then the health economics of the whole situation.